All right, folks, let's go ahead and get started. You should have gotten an email from me about that one homework question. For those of you who had already turned in your homework and maybe missed that question, everybody's going to get full points for that one question. I'm going to go back in there and regrade it now that everybody's turned it in. Because it wasn't, not only did we not talk about it in class, but it's not in your book either, that tissue hydrostatic pressure. So I apologize for that, but it's being fixed. Okay. So before we get into the immune system and its function, we're going to finish up talking about the rest of the lymphoid system. Okay, so we talked about the lymphatic capillaries last time, how they collect fluid, debris, potentially infectious material from in and around the cells of tissues and basically route it back into the cardiovascular system. And then we talked about the lymphocyte family and how in certain parts of the body, like in the malt and the tonsils, we find great big clusters of lymphocytes that, you know, it's as though the immune system has put its best pieces right where infection is likely to occur. Okay, so that we call lymphoid tissues. In other words, areas of lymphocytes in other organs. Well, there are also lymphoid organs. And this brings up this point of, well, what's the difference between an organ and a tissue? Well, a tissue is part of an organ. So all organs are made up of multiple tissues. You know, so for example, the skin is made up of multiple layers of cells of different types, like you learned about last time. You know, you had the squamous epithelial cells, the keratinized. You had some adipose tissue, you had some vessels, so multiple tissues make an organ. And typically an organ has a boundary, you know, or a capsule. In other words, under the microscope you can see where one kind of organ ends and something else begins. Now there are exceptions to that, like the bone marrow, but so the lymphoid organs all have a capsule. In other words, they're separated from the surrounding tissues. So they're easy to tease apart from the surrounding tissues. And the three types of organs we have are lymph nodes. There are tons of those, okay, hundreds in the body. But they all share a similar anatomy and a similar physiology. Okay, so there's a bunch of those. There's only one thymus up in the upper chest, and there's only one spleen. Okay, so we're going to talk about each of these in turn. So the easiest way to describe a lymph node is it is a filtration system for the lymphatic vessels. Okay, so we have all these very thin tubes filled with excess fluid, and that fluid is coursing back towards the cardiovascular system, up towards the subclavian veins, like we saw last time. Along that path, they have to pass through these filters. Okay, so a lymph node looks a little bit like a kidney, right? It has kind of an indentation at one end, and then it's sort of roundish. You can see it better here. You know, they're sort of kidney shaped. And coming in from the outside, or coming in from around the rounded part of the lymph node, are these lymphatic vessels. So like here's one, here's one, here's one, here's one. Fluid is coming in through these tubes from areas of tissue distal to where this lymph node is located. So for example, if it's a axillary lymph node in the armpit, it's the fluid that enters it is going to come from the hand, from the arm, from the lower arm and upper arm, right? So it's flowing up towards the chest, up towards the subclavian veins. And remember, this fluid that's coming in is likely to have all kinds of stuff that we wouldn't want circulating in the body in it. You know, bacteria, debris, viruses, things that you'd want to filter out before that fluid went back into the blood. So the fluid enters around the outside, and it has to pass through this massive collection of lymphocytes and other cells before it can exit the lymph node through its center, through its hilum. So a hilum is the part of an organ that has vessels coming in and out of it, all in one small space, right? So the lungs are going to have a hilum, the kidneys have a hilum, and so do lymph nodes. So we've got an artery and a vein supplying the oxygen and nutrients, right, for these cells. And then we've got a lymphatic that's going out along with the vein. So fluid enters around the outside. It has to filter past these cells until eventually it leaves the lymph node here and now heads further down its path towards the right lymphatic duct or the thoracic duct up by the subclavian veins. So these cells that are found in here are immune system cells. So as stuff passes by, if anything that doesn't belong, and the immune system responds to that right here in the filter. So not only does it work like a sponge, where big debris gets trapped in the lymph nodes, but it also acts as a living thing because these lymphocytes are alive and they're going to attack anything that doesn't belong in the body. Okay, so it's kind of a trap. Anything that is flowing through the lymph up into the chest is going to either get filtered out or destroyed by the lymph nodes along the way. All right, so the anatomy of a lymph node is pretty simple. It has these sort of wedge-shaped divisions called trabeculi, but then all of these cells in here are going to be either lymphocytes or other immune system cells like macrophages that gobble up and destroy things. So the fluid that leaves a lymph node is much, much cleaner and more pristine than the fluid that left it. Now, is it perfect? Not usually. There's so much junk in the lymph that it really takes multiple filters before that stuff is removed entirely. So for most of the lymph in the body, it passes through more than one lymph node before it reaches the cardiovascular system again. So there's multiple paths for cleaning and nabbing the infectious particles out of these things. Now, many of you, when you've had a cold or a sore throat or something like that, you'll have had a lymph node that swelled up, maybe even got kind of tender or sore. That isn't a problem with the lymph node. That's a lymph node doing its job. Okay, that means when it swells up and gets tender, that it has captured something infectious. So once that occurs, all of these cells, they send out a signal to the immune system saying we need help, basically. So immune system cells flood in to the lymph nodes and assist with destroying whatever that infection is. So it's a sign that a lymph node is doing its job when it gets swollen and tender. Now, if it stays swollen and tender for weeks and weeks and weeks, then it might be that it itself is infected. But that comes later on in that process. All right. So lymph nodes, lymph filters are essentially what they are. Okay. So we have those all around the body. Here, let me show you. I think I have a link to, here, I'll just do it the old-fashioned way. Okay, so everywhere you see one of these green dots, that's a lymph node. Okay, so we have lots and lots of them. They're clustered, though. So you have a cluster of lymph nodes here where the leg meets the trunk. You have a cluster of lymph nodes here where the arm meets the trunk. Where the head meets the trunk, you've got a string of lymph nodes there. Down the center of between the lungs, you have a set of lymph nodes there. And then you have a whole bunch of them in the abdomen that serve the digestive tract. Okay, so all of these lymph nodes are strategically placed to prevent infection from going from a distal part of the body to the central part of the body. Right? So they're strategically located to nab any infection before it gets a chance to spread out of that region. Yes?
So, is there a reason that it's not, on this, slides here, it's really,
Here you mean where are the lymph nodes for here?
Yeah.
It's because all the blood from this part of the body, it flows to the back first and then in, so they come in through here. So yeah, this area's lymph nodes are back here at the center. Good. There's a missing piece, It looks like, yeah. All right. Now I have to get back to my spot. Okay. So lymph nodes, the most numerous of the lymphoid organs. Okay, you have lots of these. Those of you who are going to take care of patients someday, you'll encounter troubles with lymph nodes. Just remember, they're part of the immune system, so of course they're going to be involved when a person has an infection. It doesn't mean that, oh, this infection is particularly bad. It just means that your patient has a working immune system. So the lymph nodes are getting activated to fight off that infection. Oh, another spot that you'll hear about lymph nodes clinically is in cancer. Okay, so not only can infections spread through the lymph, but metastatic cancer cells can too. Because these work like filters, the most likely place for a metastatic cancer cell or little tiny tumor mass to get stuck is in a lymph node. So like in breast cancer, for example, when it begins to metastasize, the first place that tumor appears is in the axillary lymph nodes here. Because the flow of lymph from the breast is either towards the center or towards the outside and then back in. So oftentimes when we go to stage a cancer, in other words, how far advanced is it, first we look at the tumor itself, and is it very well contained, or does it have like tendrils into the other tissues? And then the next stage is, has it spread to the nearby lymph nodes? Because if it has, it says this tumor is shedding pieces of itself, which means once it gets past the lymph node system, it's likely to appear as a secondary tumor somewhere else. Okay, so, and you'll learn all about the different cancer stagings later on. But in aggressive cancer surgery, usually the tumor is removed as well as the lymph nodes that drain that region. Okay, so again, like in a mastectomy, they'll oftentimes remove not just the tumor, but surrounding breast tissue and the lymph nodes from the axilla, which is the most common place for breast cancer to spread. Because essentially, the breast tissue is just underneath the skin, so it drains like the skin of that region does, which is towards the axillary region. Yes?
Do the lymph nodes grow back?
No, the lymph nodes do not grow back. Like if they're removed in surgery, they won't grow back. You can grow new lymph nodes, but it's never going to be the same. But you have extra. So it's not like your risk of infection goes up, because there's many other lymph nodes along that path. But yeah, they don't ever grow back. All right, so lymph nodes. And they look boring. They look like this little tiny thing. And you have lots and lots of them. I mean, some of you will get to work with a cadaver someday. You'll find, like, in between the lungs, I mean, it looks like they're like little tiny bunches of grapes. I mean, you'll have a whole bunch of them in certain regions that are very active. All right. So the second class of lymphoid organs is the thymus, okay? Not to be confused with the thyroid. Okay, the thyroid gland sits just underneath the Adam's apple. The thymus gland sits below the level of the clavicles. Okay, as you see the clavicles here coming straight across. So they're in the chest, they're not in the neck. The thyroid gland is in the neck. The thymus gland is in the upper part of the chest. So it sits between the right and left lung, superior to the heart, and anterior to all the great vessels. So in front of the aorta, in front of the brachiocephalic vein and subclavian vein, sits the thymus gland. It has two lobes and a very loose organization. When you look at the thymus gland, it's hard to tell it apart from the surrounding fat that's also in that region. So it has this very loose organization anatomically, which you can kind of see here. It is divided into lobules, which are just little compartments. And we've got a picture of, well, I guess I don't have a picture of what that looks like, but it looks in many ways a lot like fat does. Only instead of having lipid stored up in these lobules, there's bunches and bunches of lymphocytes in there instead. So what you find in the thymus gland are lymphocytes, particularly T cells, learning about what normal is what the thymus is for. So T cells are born in the bone marrow. They travel off to the thymus, where they spend sometimes years being exposed to the body's normal pieces and parts. Because once they've figured out what normal body cells look like, then they're released into the circulation and they go looking for anything that isn't normal, right? So before they can identify abnormal, they have to first know what normal looks like. So that is sort of what happens in the thymus gland in a nutshell. So the thymus is most active between birth and puberty. And the reason for that is that's the time of our lives when we are building up our immunity to the local germs, right? Different parts of the world, even different regions of one country, even different regions of one city have different pathogens that are endemic, that are around all the time. So in our youth, from birth to puberty, our bodies are exposed to these new pathogens all the time because they're new to the individual, even though they're not new to the species. So by the time puberty is reached, most of our immunity is already established. So the need for the thymus gland starts to decrease. And as that occurs, the thymus gland starts to shrink. So like this picture is the thymus gland of probably a 20-year-old, let's say. Because in a 3-year-old, the thymus is much larger, like it's like this, right? And in a 50-year-old, you can't hardly find it. It looks basically like a thin layer of very weak scar tissue. You can't, like in our cadavers, you can't even identify because they're all 80 plus years old and their thymuses have long since disappeared. So it's very active in children, sort of active in young adults, and it's practically gone by middle age. So we lose our thymus over time. Now, does that mean we lose our immune system over time? No. It's by the time we get to 25, 30, our immune system has already learned all about normal, so it doesn't need to do that anymore. It's just going to learn about abnormal from that point forward. All right. Okay, so thymus. And then the last of the organs for the lymphoid system is the dear spleen, right? So the spleen is hugely unappreciated, in my opinion, but it lives up underneath the diaphragm, behind the ribs on the left side. Okay, so on the right side, the whole right quarter of your abdomen is taken up by liver. Okay, the liver's a huge organ and quite heavy. But tucked up on the other side is the spleen, so back here. So this is a cross-section at this layer. So you can see that like half of the abdomen is taken up by liver. This is all liver. Here's the stomach. And then way back behind the stomach, just next to the kidney on the right side, is the spleen. Now the spleen lives in this region because it's very well protected here. The spleen is a soft organ that has a pretty tough capsule, which means it's a little bit like a balloon. A balloon has a hard outer shell and soft stuff inside, air, right? It means that the spleen can rupture. Just like a balloon, you can pop a balloon because the insides are a lot squishier than the container. You can also rupture a spleen in that same way. So evolution, over time, the spleen has arrived in this very protected place on the right side, because it's protected in the back by the ribs that come down, particularly the 11th and 12th ribs that don't connect to anything. On the side, it's protected by the regular ribs that are coming around towards the front. And then in the front, it's protected by the abdominal contents like the stomach, and then, of course, the abdominal wall as well. So it's in a safe place. Now, does that mean spleens don't get damaged? No. Because they have a tendency to rupture, any significant force, either to the flank, particularly on the right side, like in a football hit that's a little high, bam. In a car accident, sometimes in a fall to the side, the spleen will break. And the spleen is essentially a blood filter. So it's very sponge-like, and huge amounts of blood flow through it. So you can imagine that when a spleen ruptures, there's tons and tons of bleeding. which is why sometimes spleens are removed, because in order to save the patient and stop the bleeding, the spleen has to be clamped and pulled out. So its anatomy is very simple because it's soft and squishy, like a water balloon. It just takes the shape of its surroundings. Okay, so the top part of it is really sort of smooth and dome-shaped because it sits right underneath the diaphragm, which is also smooth and dome-shaped. And then on its front, or its medial surface, we see impressions from the different organs that surround it. Now, this is an anatomy slide, but there isn't much for you to know here. All I want you to know is these three things: splenic artery, vein, and the lymphatic vessels. In other words, the hilum. You don't have to know I'm not going to ask you much about the spleen anyway, because it's a boring little organ, really. But it is it's an immune system organ. Why do we have a spleen? Fights infection. Particularly, the spleen is our blood filter. Okay, so lymph nodes filter the lymph, that extra fluid collected from the tissues. The spleen filters the blood. So in people who don't have spleens, they are at much greater risk for blood infections and blood-borne infections. So much so that if you don't have a spleen, every time you have dental work, you take antibiotics for a couple of days. Because every time you have dental work, some bacteria gets into your blood, goes around your body. Without a spleen, there's nothing to take that bacteria out, and the patient is at increased risk for blood-borne infection. So it's not that we don't need a spleen, okay? It's that we can live without one, all right? Because sometimes people put this in the list of organs we don't really need. No, we can live without a spleen, but when you have a spleen, you're much better off than when you don't have one. Yes?
So is it just kind of like your tonsils, like when you lose them, like you're just probably going to be most likely exposed to more.
Right, you have an increased risk for illness, and with the spleen in particular, more so than the tonsils, you're at an increased risk for severe illness. So like something, a transient bacteria in the blood, for somebody with a spleen, you never even notice. Somebody without a spleen, they can get sick and end up in the hospital because they don't have that natural filter. Yeah?
Does all the blood filter through the spleen in order for it to pull out the infection?
Eventually it does. I mean, all the blood doesn't go there every time. But, over the course of a day, all the blood has passed through the spleen a few times. Yeah. So it goes in through the arteries, comes out through the veins, and it really is like a sponge on the inside.
So how many arteries or veins go in through it, or are they big?
There's just the one artery and vein going in, but then when it gets in here, they spread out into a whole bunch of things. Yeah. It's like taking a funnel, turning it upside down, and putting a sponge underneath it. You can run water through the top, and it'll drip all the way out through the bottom. Yeah, it's like that. So there are a couple of places where the spleen comes up, and we talked about trauma. Anybody in here had spleen damage? I know we've got some athletes in here. Sometimes it occurs from a body blow to the side. Car accidents, another big thing. Where this comes up in young people that many of you may have experienced. Anybody had mono and had to sit out from a sport? There's one, there's two, yeah, there's always a few. It's because mononucleosis makes your liver get big, and it makes your spleen get big. Well, a big spleen is more fragile than a normal spleen is. And when the spleen gets big, instead of sitting underneath the ribs like this, its edge starts to poke down here. So we don't let people with big spleens play contact sports. So we sit people on the bench, because with a big spleen, you catch a blow from the side and you might die, which is not worth it, right? So it's better to sit out the semester, even though young people are often very upset by that. But better to not die than play the sport for one less semester. Okay, so that's this little spleen talk. Okay, let's do some questions. So compared to blood capillaries, this one's from last time. The lymphatic capillaries have all these features except one. Let me find that one. Multiple choice. There. I'm not getting answers. Is it working? Is it saying something? Oh, now I'm getting answers. Okay, there we go. So everybody hates these accept questions, right? So I put them up here sometimes to just go through some test-taking strategy too. So essentially what they're asking you here is, which of these things is not true, is a way to look at an accept question. So which isn't true? So compared to blood capillaries, do lymph capillaries have no basement membrane? Which we didn't talk about that, but they do not. So that one's true. Blood capillaries are larger in diameter than lymphatic capillaries. Is that true? No, that is not true. So we can kind of stop there because we found it, right? But lymphatic capillaries also have endothelial cells that overlap like shingles. I drew that on the board last time. They're smaller, and they're very irregular in shape, because they have such thin walls, their shape is just determined by the cells around them. All right, so most of the lymph returns to the circulation by way of which of those structures? So the key word in this question is the first one, most, because lymph returns to the venous circulation by two paths. One is on the right side, we call that the right lymphatic duct, where it enters the right subclavian vein. And then on the left side, we have the much larger thoracic duct, which drains not just the side of the head and the right arm, but the whole rest of the body. So 75% of the lymph returns to the circulation through B, the thoracic duct. Okay. Which of these statements about lymph flow in a lymph node is false? Let's see if you remember your vocabulary from last semester, because we talked about these words before. Because in three of these answers, you've got these very pesky words, and it isn't just some of you that wish they had picked different words. I wish they had picked different words too, because these are just too much similar. But afferent always means going out. And efferent, sorry, I just messed that up. See? Afferent is going in. Efferent is going out. The only way I've ever really remembered this is in the nervous system. Efferent makes effect, right? Now, unfortunately, there's also a word affect with an A, so it's not that helpful. But that's just my own personal mnemonic. So if we look at these, lymph enters in an afferent lymphatic. So that's a lymphatic going in. So, okay, that makes sense. Yes, it enters the subcapsular space first, because that's what that picture showed. Does flow past the dendritic cells. That makes up that cell mass. And then, so it's D or E. Well, efferent is leaving, so it's D. The efferent lymphatics exit at the hilum. Okay. All right. Okay. So we change gears here because the whole rest of this chapter is about this exceedingly complex topic of the immune system, right? It's a class all by itself. I think many of you will someday take that class if you haven't already. I know a couple of you have already. And that class is immunology. And of all the things in medicine that have changed in the last 50 years in terms of how we understand things, the immune system has really been a big piece of that. A lot of research has been done because even 50 years ago, we knew very little about how our bodies fight infection. And today we know a ton. And, well, many immunologists would say, and we still have a ton more to learn. It's a complicated system, and part of the reason for that it's complicated is it has a complicated task. There are an infinite number of microorganisms on this planet, of apparently infinite number of species. So our immune systems have to be able to discriminate between our own healthy cells, beneficial microorganisms like you find in the gut, and then a whole slew of pathogenic organisms. So it's a big task, which means that the system has evolved to be quite complex. And like all complicated things, we take it apart and look at it in pieces, right? So that we don't have to consider the whole thing at once. So ultimately, this system protects us from anything that doesn't belong. That's how I think of it. So that's bacteria, viruses, that's mutation. Cancer, as we see it diagnosed, is the end of a very long process of mutation. Each and every day, we have cells that divide and become mutant. They don't divide exactly correctly. So why don't we all have cancer all the time? Because most of those mutant cells are destroyed by our own immune system. So we see this in patients that have immune deficiency, where their immune system is not functioning properly. Their risk for cancer skyrockets. And it's because one of the things our immune system does is protect us from ourselves. Our cells are not perfect dividers, which means sometimes you get a cell that's kind of got its own idea about how it's going to divide, and without the immune system, that becomes cancer. Toxins are attacked by these, as well as the immune system is our built-in cleanup crew. So, you've got somebody hit you in the arm, you got a nasty bruise. Well, why does it go away? Well, in part, that damaged tissue is swept away by the immune system so that new healthy tissue can heal back in its place. So we ask a lot from this system. And the two big divisions that we look at in the immune system, so immunity. So we have two big branches. We have the nonspecific, which we also call innate. An innate thing is something you're born with. Okay, it's you didn't have to grow it, it didn't have to learn, it didn't have to develop. You had it on day one. You actually had it before day one, because even fetuses have a nonspecific immune system. And then we have the specific, which is also called acquired. Okay, so let's look at the first adjective first. The non-specific and specific, well, what difference does that make? This branch of the immune system, all attacks are the same. Okay? So it doesn't matter what the pathogen is, what I mean there. If you've got 10 different kinds of bacteria, the non-specific, the innate immune system is going to attack all of those bacteria in the same way. So it doesn't discriminate between different kinds of pathogens. Whereas on the acquired branch, each pathogen gets different response. So that's how it gets, we call it specific and nonspecific. In other words, each pathogen gets a specific, individualized response, where here, all the attacks are the same on any group of pathogens. All right? So then what about the second adjective, innate versus acquired? Innate, we're born with this. And acquired, we have to grow. I'll say have to grow. Another way to look at it is our immune system has to learn. Okay, so we have these two broad groups. Now, like most things that we take apart, it's not like they are always separate. The truth is, there's a great big giant arrow in here where they work together, because they do. Now, the acquired side of things is the more complicated side, and it's more effective. But it takes longer to work, and it takes longer to start. So even though, in the end, this is better, in the short term, right this second, like if you were to suddenly have somebody sneeze on you, for example, with all kinds of bacteria or virus in them, then this is practically instantaneous. So this is slow, but effective. This is fast, but needs help. And the help, of course, comes from the other side there. Okay. And so in our talk about this, we're going to start over here, because this is the more simple stuff. And then we're going to work our way into the acquired. So this is lymphocytes, make up the acquired system. And this is, we'll say, rest of WBCs, rest of the white blood cells are in the nonspecific. Now there's some other players there too, but that's a good summary. Okay. So what are some examples of these nonspecific defenses? We'll talk about each of these in turn, but I'll just kind of go over them in this slide, and then you can read up on them in the others. Okay, so there's this long list. So one of the first defenses we have, and this is defenses against the outside world, defenses against pathogens, toxins, anything that doesn't belong. So one that is often forgotten about until it fails are the physical barriers. So the thing that keeps most microorganisms out of us is our skin mucous membranes, are those two things. Those epithelial tissues that you learned about last semester, they have rapid cell division, which means that no cell, like on the inside of your mouth, protecting your tissues from what you eat, is more than a week old. Okay, so these cells are always brand new, which means they're vigorous and tough. They can very easily rebuff or repel infection. Same thing with the skin. We not only have our keratin shell, that keeps bacteria and other microorganisms out, but we also have a layer of little hairs, too, that assists with that. And assists us in identifying, when there's an insect on us, for example. So physical barriers play a major, major role. You see this in particular when those barriers are broken somehow. So like in a patient who has a bad burn, that area of burned skin has, many, many times the risk of infection as intact skin does. So one of the things we worry about in a burn is infection, because once you take that skin layer away, the underlying tissue really doesn't have any defense, except for the rest of these more active defenses. So the physical barriers always play a major role. Next in line after that are the phagocytic cells. These are cells that engulf and destroy things that don't belong. We saw some pictures of one in our white blood cell talk, the blob chasing the thing. Well, some phagocytes are blob-like and they chase stuff. Others are more like ambush hunters. So macrophages, for example, our tissues have resident macrophages. They just sit there in the tissues waiting for something to appear that doesn't belong. And then once they do, they sort of reach out a foot, grab it, pull it in, and swallow it and destroy it. So they sit there sort of standing guard. And any cell that can do phagocytosis, pull something in and destroy it, lives in this category. So we have the macrophages. The neutrophils, of course, are cells that do that, as are the eosinophils that we learned about in our white blood cell chapter. So these are, well, from here on down, are all active defenses. So physical barriers are passive. They exist, and therefore it creates a barrier. All of these guys defend us by doing something. Okay, so like in this case, destroying anything that doesn't belong. Next on down is the NK cells that we talked a little bit about last time. So immunologic surveillance is the concept that we have cells in our body that are always on the move, and they're always looking for cells that have a problem. Okay, so the best analogy is like the police, that they are on patrol all the time. They're driving down neighborhood streets. They're looking for anything that is not right or anything that doesn't belong. Well, the NK cells perform that function in our bodies. They circulate for years on the move. They cruise around. They go through the different tissues. And biochemically, they're always on the lookout for cells that are mutated or cells that are infected by a virus or bacteria. And we'll talk about how they do that later on. But this is one of our non-specific defenses. Immunologic, in other words, immune system, surveillance, keeping an eye on things. We know now that this surveillance is a big player in cancer prevention. That the reason that cancer rates are relatively low, despite the fact that cells do become mutated as they divide, is because these cells pick them up. They see that the cell is mutated, and boom, they destroy it. Now you'd think, well, isn't destroying the cell a bad thing? No, because cells grow back pretty easily. You just get another division, and okay, it's all fixed. So it's better to kill it when it's one cell than when it's thousands. Yes?
So are the phagocytes like more dormant and the immunological ones are more mobile? Or what's the difference?
The immunologic ones are more mobile. They're active all the time. They're moving and searching. They're searching. These guys wait for something to turn up, or if something has turned up, they swarm it. So they can become very active, but the phagocytes that are in your tissues in an uninfected place are just sort of sitting there, waiting for something to happen. Does that kind of answer your question?
Yeah, yep, thank you.
Okay, so moving on down, the next are some chemicals. Interferons interfere with viral infection. So that's what they interfere with. This is kind of a cool system that evolution brought about. When a cell is infected by a virus, it's like it has a little trick up its sleeve. Okay, so you've got this cell, and it's been infected by a virus, and the virus is turning it into a virus-making machine, right? We've all heard about that. Well, while that cell is churning out copies of virus, it's also throwing out these chemicals called interferons, which make its neighbor cells much more resistant to infection. So while this cell is getting infected and dying, it's helping its neighbors to not be infected. So it's kind of a nice... Our systems are not as good with viruses as they are with bacteria. But the interferon system certainly does help. It means that viruses can't just kill a whole row of cells one after another, because the interferons help the neighbors to be stronger so that they don't get infected in the first place. And this is a group of chemicals that we now know how to make. We're still learning how to use them in the treatment of patients. Because, you'd think, well, if we just give a bunch of interferon, won't that cure a viral infection? No, but it will help get that treated, or it will help reduce the symptoms and things like that. So you all will hear more about interferons in your careers than I did in my short one in medicine. Okay, so that's those guys. The complement system is a biochemical attack. It's a set of proteins that are found in the plasma, in the blood, all the time. And when a bacteria or other pathogen is present, these proteins self-assemble into a kind of spear that punches holes in cell membranes and cell walls. So one of the reasons our blood is very resistant to bacterial infection is when bacteria are present, the complement system forms up and punches a hole in their cell membrane. And you know that cells that have a big fat hole in their cell membrane are probably not going to live for very long, right? Because their insides go to the outside goes to the inside, and the cell dies. So that's the complement system. This is one of the more complicated bits that I leave out in the immune system chapter because it's a very elaborate biochemical system. But all I want you to know is that self-assembles, pops a hole in the side of a bacteria or bacteria-like cell and destroys it. Okay, then we get down to inflammation. Inflammation is the body's common response to any kind of injury or infection. All right, and ultimately it's 3 R's. So inflammation, and you've all experienced this in your life. Okay, so it's redness, swelling. I guess it's not 3 R's, but warmth. I don't know what I was thinking there. It's 4 things. So inflammation, redness, swelling, warmth, and pain. These 3 things are all from the same thing, and that is increased blood flow. Okay? The more blood flow to a region, the redder it gets, right? Because blood is red. The more blood flow to a region, the warmer it gets, because blood is warm. And typically, the more blood flow to a region, the more swollen it gets. Now, there's another piece to that, which I'll talk about in a minute. But whenever the body is damaged or infected, the damaged cells or infected cells release chemicals. And those chemicals trigger these changes, okay? So one thing that's triggered is an increase in blood flow, so vasodilation. For the swelling, we get increased capillary permeability. That means capillaries get leaky, okay? And you might think, well, how's that a good idea? Well, a damaged tissue needs to have more fluid for a couple of reasons. One is so that these immune system cells, the white blood cells, can get to the damaged area, right? That the capillaries have holes in it, easier for the white cells to get out. It also puts a little extra fluid around so that the cells have room to move and work to clean things up. It also helps to wash out toxins and debris. So when you've twisted your ankle, for example, and the next day it's twice its normal size, it's because of this increase in capillary permeability. Now, have the cells gotten bigger? No. It's just there's more fluid around the cells that were there already, so that the immune system has some more room to work. And that comes as a combination of an increase in blood flow and an increase in permeability. And then the last one is pain, and it also comes from chemical mediators. Chemical messages, basically. And while nobody likes pain, it is an important part of our immune response because pain tells us, it signals us that there's something wrong with some part of our body, right? How do you know that you damaged the ligaments in your leg or your ankle when you twisted it? Well, in part because it hurts, right? So it notifies the body. It also has a tendency to protect an area. If your ankle has been damaged by a twist and it hurts, well, you put less weight on it, right? So you give the ankle some time to heal, too. So that's inflammation. And primarily, one of the ways this comes about is histamine. So last point, I promise. I want you to associate inflammation with histamine, which is one of these chemical mediators that triggers inflammation. All right, but we are out of time, so I'm going to stop right there.